So welcome everyone to ISA Presents. And today it's my great pleasure to be handing over to my friend and colleague, Zan Leisher, who's going to be talking to us today. On structural racism and black-white disparity in stillbirth rates in New York City. So Zan, I'd like to hand over to you now. So the way this will work is Zan will be talking to us around her research, her findings, and then following that, we'll have a time for questions. So please do type your questions in the chat as we go along, or save them for the end. We'll have a chance to have a conversation. So over to you, Zan.
Thanks so much. It's so good to be here. I really appreciate the opportunity. And I'm just going to share my screen and start the PowerPoint. So does everybody see that okay? No?
Yes, that's great. Thank you very
Oh,
much.
good. Oh, perfect. Okay.
Yes.
Okay. All right. So, excuse me. Right. So I'm speaking on structural racism and black-white disparity in stillbirth rates in New York City. This formed part of my dissertation research. I always like to start with a couple of pictures that give my reason for focusing on this work. The left hand is a picture of me when I was pregnant with my first child, and the right hand is a picture of me holding my first son, Wilder Daniel, who was stillborn at 38 and a half weeks in 1999. And I'm going to share the next slide, which has two photographs of Wilder as a stillborn baby. So if you prefer not to look, then then don't. So this is my son, and he is my reason for being here today. I'm going to share some context about why I did the study, and then some details of how I did it and what I found, and then I'll comment on sort of the conclusions that I reached. But I did want to preface this by saying that I have two aspects of my identity that really inform my work in this area. One of which is, of course, the fact that I'm a stillbirth parent, but the other is the fact that I'm a white person looking at racism in black-white disparity in stillbirth rates, and that absolutely affects the way I understand and carry out this work. So many of you have seen several of these contextual slides. I always like to set the stage by taking a global perspective. Stillbirths comprise 1/4 of all deaths to mothers and children under 5, and that is only counting late stillbirths. The situation is very similar in the United States, where stillbirths comprise half of all infant deaths and stillbirths. Also, something that's not well understood is that there are twice as many stillbirths in the United States as there are deaths from all causes to children aged 1 to 14. So a key part of the reason for any research on stillbirth is just simply the sheer burden. Also, 1/3 of stillbirths are unexplained. The pie chart on the left shows the array of causes in low-income countries, and the pie chart on the right shows the array of causes of stillbirth from high-income countries. And you'll see that in both contexts, between 30 and 40% of stillbirths have no explanation. Again, this is similar in the context of the United States, where 31% of stillbirths in 2019 were completely unexplained. So not only is the burden of death very large, but we don't have an explanation for a large proportion of those stillbirths. In the United States, there are very large racial inequities in stillbirth rates. Here you can see that although the US stillbirth rate was 5.7 per thousand total births, the stillbirth rate in several of our racial and ethnic minority groups is much higher. These data are also from 2019, and they show that the stillbirth rate in non-Hispanic Black families is nearly twice as high as it is in non-Hispanic white families. Similarly, the stillbirth rate in Native Hawaiian and other Pacific Islander and American Indian Alaska Native families is much higher than it is in white families. In terms of the Black-white disparity in stillbirth rates in particular, this doubled risk of stillbirth has existed since at least 1950. On the left-hand side, you see the orange, sorry, the whole chart shows Black stillbirth rates represented by the orange triangles and white stillbirth rates represented by the blue squares. And you can see that at every year, that orange triangle is twice as far from the x-axis as the blue square, meaning that there has been a doubled risk of stillbirth for Black as compared to white families for many, many decades. The racial inequities in stillbirth rates also appear in the risk of recurrence of stillbirth. So we have some very, very large studies showing that, generally speaking, the odds of stillbirth happening again are quite significant. The odds of stillbirth are 5 times greater if your first pregnancy ended in a stillbirth. This is a study from over 3 million pregnancies in high-income settings. The odds of stillbirth are nearly doubled if your prior pregnancy ended in stillbirth. This is a study from the Netherlands of almost 300,000 births. But if you are African American, your odds of stillbirth recurrence are nearly triple that of white moms. Also, and so despite the huge burden and despite the racial inequities in stillbirth rates, there's very, very little knowledge about those inequities. And so this is the stillbirth, Ending Preventable Stillbirth Scorecard that was developed several years ago by the Stillbirth Advocacy Working Group. And we took a look at whether there's any data at the global or regional or even country level for stillbirth rate equity. And you can see by the inside the black ring there is no data. There are very few countries who set a stillbirth equity target, and there's no tracking of whether there's any progress in reducing stillbirth inequities. There is a wide range of causes and contributing factors for stillbirth, and we see that range of causes reflected here. We've got maternal factors such as, does mom smoke? What is mom's prenatal birth prenatal weight? Did mom get proper antenatal care? Some of the causes relate to the baby. Is the baby male or female? There's a higher stillbirth rate in males, etc. There are causes related to family, community, health system, and also at the structural level. However, the focus of research has largely been on those individual factors, generally at the level of the mother or the baby. And we don't know a lot about the causes of stillbirth and contributing factors at the health system and structural levels. Some research that I did that hasn't been published yet looked at the literature on Black-white disparities in stillbirth rates in the United States, and I found over 80 reports that looked at Black-white disparities in stillbirth rates, and the vast majority of them only carried out analytical exploration related to fetal and maternal factors. So you can see that fetal and maternal factors, fetal and maternal causes of stillbirth were investigated in 30 to 40% of those reports, whereas all other factors related to family, community, and the structural level, very small numbers of reports looked at those factors. And so all of this context is what led me to ask the research question, could a structural factor, could structural racism help to explain the Black-white disparity in stillbirth rates in the United States? So I want to talk a little bit now about how I carried this study out. So there's a lot of words on this page. Sorry for that, but I looked at over 1 million live births and stillbirths that were registered with New York City's Department of Health and Mental Hygiene in the 10 years from 2009 to 2018. I excluded anybody who was not a resident of New York City. I excluded births that were under 20 gestational weeks, and I also excluded multiple births. For my individual level data, I took that from the Vital Statistics Registry in New York City, as well as the Spontaneous Terminations of Pregnancy Registry, which is where stillbirth data is housed for New York City. And at the group level, I accessed the US Census, the American Community Survey, as well as some data from the New York City Center for Economic Opportunity. So structural racism is by definition a group level variable, and so I needed to choose the group level at which to carry out my analysis. And the level that I chose is called the Public Use Microdata Area, which is also known as the PUMA. And here on the right, you see a map of New York City showing the 55 PUMAs in New York City. Each of these PUMAs has at least 100,000 residents by definition. And yeah, so that is the level that I chose. So then I had to decide how to measure structural racism. And as we know, structural racism is an incredibly complex, self-perpetuating set of factors at multiple levels, with historical factors and legal factors, factors related to culture, practice, and policy that all are embroiled together to create this environment, this oppressive environment. So I had to pull out from that ways to measure structural racism, and that literature is extremely rich. I selected four proxies for structural racism out of dozens and dozens of options. These were the index of isolation, which measures the probability that minority and majority groups will come into contact. The index of dissimilarity, which measures how closely racial distributions within a neighborhood mirror the larger racial distribution of a larger region. Those two indices are, they were created in the 60s or 70s, or no, sorry, even earlier, I think the 40s or 50s. They are well-known indices of structural racism, and they have been used in many studies, including the only studies to date before mine of structural racism and stillbirth. So I thought I should include them. I also chose the index of concentration at the extremes. Unfortunately, the acronym is ICE. And this measures the degree to which a neighborhood is composed of individuals who are, quote, privileged versus disadvantaged. And it's a nice measure because you can define privileged and disadvantaged in multiple ways. And then finally, I chose an educational inequity ratio to assess the relative educational attainment of Black versus non-Hispanic white adults. This is just a screen showing the formulas and so on. I won't dwell on that, but happy to answer questions. My analytical approach was that I started out by excluding births that do not have data on PUMA. There were about 300 births over the course of the 10 years that lacked birth location. And then I carried out multi-level logistic regression, and I tested for interaction between race and structural racism proxies. Importantly, of course, I had to identify how to assess birth race, and so I followed maternal race, which is self-identified as per the U.S. Census guidelines and allows 2 or more races to be identified by the individual. I define non-Hispanic Black as one race only, and as Black and either not Hispanic or missing the Hispanic reporting, and similarly for non-Hispanic white. So I screened out the structural racism measures that didn't show any evidence of differences by race, and then I carried out my subsequent analyses in Black births and in white births separately. I adjusted for year of birth, maternal age, and maternal education, as well as at the Puma level, I adjusted for the proportion of individuals living under the poverty line as defined by the New York City government. And I did a lot of sensitivity analyses. So sensitivity analyses are ways to kind of poke at your model to see how robust it is and whether it's just dependent on a couple of factors or whether you keep seeing the same results over and over no matter how you look at it. And also just a comment, when I say I adjusted for these factors, um, that's just a way of trying to ensure that the analytical model takes those factors into account and isn't swayed by them. Happy to go back on those kind of technical, but happy to go back and answer any questions. But I just wanted to get to what I found. So I'm going to talk a little bit about some of the descriptive data and then get into my analytical model results. So I found that the stillbirth rate in New York City was 7.6 stillbirths per thousand total births, which is substantially higher than the national average. And I also found enormous variation in stillbirth rates across neighborhoods. So this chart shows the 55 Pumas, which, as you recall, are neighborhoods consisting of about 100,000 folks each. Each of the orange bars shows the stillbirth rate in an individual neighborhood, and they are organized according to the 5 boroughs. So New York City has 5 boroughs, or very, very large neighborhoods, if you will, and within them are a multitude of smaller neighborhoods. The highest stillbirth rate that I found was in one Puma in Brooklyn, where the stillbirth rate is 15.1 stillbirths per thousand total births. Just let that sink in. The lowest stillbirth rate I found was in one Puma in Manhattan, where the stillbirth rate was 2.8 per thousand total births. So an enormous variation. The stillbirth rate in this neighborhood is 7 times higher than at another part of the city. I'll also note that this apparently was the first time that the stillbirth data in New York had been analyzed. Another thing I found was that there was a lot of missingness in the stillbirth data. So here, this pie chart shows all 1,068,000 live births across that 10-year period, and you see that 51% were male, 49% were female. Here is the sex for the 8,177 stillbirths in that 10-year period. 17% of those babies had a missing sex in their data. And I highlight that because how hard is it to assess the sex of a baby? I mean, it's not hard. And so to me, this is very striking. There was a lot of other missingness in variables that are harder to capture. But sex is not one of those variables. And so I thought that was quite striking. I found, no surprise, that there are very high racial inequities in the stillbirth rates in New York City. So here you see that the non-Hispanic Black stillbirth rate is 13.8 per thousand total births in New York City. The white stillbirth rate in New York City is 4.7. That's an enormous differential. And it's a far greater differential than it is at the national level. Remember, at the national level, the disparity is about double, only double. Here it's nearly triple. I also found high stillbirth rates in the Hispanic population at 6.2 and in the non-Hispanic Native American population at 7.7. I found some interesting differences in the patterns of stillbirth risk between Black and white families. So here we have got the stillbirth rates for different subgroups. We've got the stillbirth rates by different groups of gestational age, sex, maternal age, education, and the borough where the mom lived. The blue bars show the stillbirth rates in Black families, and the orange bars show the stillbirth rates in white families. And remember that overarching stillbirth rate in Black moms is 13.8 versus 4.7 in white moms. But if we look at the pattern of risk, for example, depending on how old the mom was, for white moms, the highest risk is in teenage moms here. But in black moms, the highest risk is in the oldest moms, those over the age of 35. And if we look at the borough where the mom lives, the highest risk for white moms is in the Bronx, but the highest risk for black moms is in Staten Island. And I think the variation in the patterns of stillbirth risk is really important for public health. We think about public health messaging, and are we messaging to teenage moms? Are we messaging to older moms? Things, you know, these types of this type of data can help to inform those strategies. Anyway, getting to my analytical results, this table is a very busy table, and I'm just going to walk you guys through it a little bit. This is the summary of my my analytical findings. Remember that I had identified four proxies for structural racism that I wanted to examine. Two of those, the index of isolation and the index of dissimilarity, showed no variation between black and white moms. So I didn't continue my analysis with those two measures. However, or sorry, the index of dissimilarity and the educational inequity ratio, there was no variation across race. However, for the index of isolation and the index of concentration at the extremes, there was variation across race. And so I did carry out my analysis for these two measures of structural racism. On the top, we see the index of isolation. I divided that into tertiles, into thirds, where tertile 1 represents the least isolated neighborhoods and tertile 3 represents the most isolated neighborhoods. And then for ICE, I divided that into quintiles, into fifths, just following what other researchers have done. Excuse me. Where the first quintile represents neighborhoods with a heavy concentration of disadvantaged individuals, and quintile 5 represents a heavy concentration of individuals of privilege. And what I found is that Black mothers have a 54% higher odds of stillbirth if they live in privileged neighborhoods as compared to disadvantaged neighborhoods. For white mothers, there was no difference. There was no significant difference in whether they lived in neighborhoods of privilege or disadvantage. I also found that Black mothers had a 36% lower odds of stillbirth if they lived in the most isolated as compared to the least isolated neighborhoods. And again, I found no difference in white moms. So just to emphasize again, what I found is that for white mothers, there really wasn't a lot of variation in your stillbirth risk depending on whether you lived in a privileged or an advantaged neighborhood. But for Black mothers, I found a 54% higher odds of stillbirth for those Black moms living in privileged as compared to disadvantaged neighborhoods. This was supported by my my finding of differences in the patterns of risk associated with structural racism. So this is just raw data here. I'm not adjusting for anything here, but you can see that for white moms, their highest risk of stillbirth was in neighborhoods where there's a concentration of disadvantage, although it wasn't significantly different from neighborhoods with concentrations of privilege. Whereas for Black moms, their highest risk of stillbirth was when they live in neighborhoods of privilege as compared to disadvantage. So the opposite patterns of effect. So the conclusions I reached based on these observations are that structural racism, as measured by this index of concentration at the extremes, is associated with stillbirth in Black moms, but not white moms. So this suggests that it could help to explain the Black-white disparity in stillbirth rates in this setting. because residents in neighborhoods of privilege as compared to disadvantage nearly doubles the odds of stillbirth in Black moms. However, part of kind of doing due diligence in any analytical study is to look at what the rest of the literature has found and see whether, your results align with that literature. And in my case, they don't. Um, there were no other studies that looked at stillbirth and ice specifically. However, there were 3 studies that are shown in this table here that looked at the index of concentration at the extremes in relation to similar outcomes: preterm birth, infant mortality, and preterm mortality. And in those other studies, they found that residents in neighborhoods of disadvantage increases your risk of stillbirth, not decreases your risk of stillbirth. So my question to myself is, how come there was a difference between my results and what's shown in the literature? So some possibilities are that there may be unaccounted, that these other studies may not account for variation by race. And indeed, the other studies, there's one by Huyn, one by Janovic, and one by Krieger here, all of those studies looked at Black and white births together. And if you recall, I looked at Black births separately and white births separately. And we saw that the patterns of risk are opposite for Black births and white births. So if you chuck them all together, and also bear in mind that there are going to be many more white births than Black births in many settings, so the numbers will be larger, you can perhaps kind of overwhelm and render invisible any pattern of risk that is distinct to Black moms. So that's one possible explanation for the differences between my results and the rest of the literature. Another possibility is that structural racism measures may behave differently depending on the level at which you measure them. So remember, I measured structural racism at the level of the PUMA, where we've got about 100,000 individuals in each PUMA. These other studies measured at the census tract level and the zip code level. Those are much smaller, more granular neighborhoods with smaller numbers of individuals. And it may be, and in fact, the literature does suggest that structural racism manifests differently at different levels of measurement. And then another possibility is this kind of very wonky concept called live birth bias. Basically, the other studies did not include stillbirths at all. So they did not include babies who died before birth. And there's been some analysis that suggests that that can have a big, big impact on the results that you see. So I can go into that. So what are some possible reasons why for Black moms, their risk of stillbirth may be higher if they reside in privileged as compared to disadvantaged neighborhoods? It's possible that reproductive health care is worse for Black women in neighborhoods of privilege as compared to disadvantage, perhaps related to increased provider bias in those neighborhoods, in the facilities that are available in those neighborhoods. That may be the case. And it also may be that there is greater and or more constant exposure to psychosocial stress for Black women living in neighborhoods of privilege as compared to disadvantage. This can be due to increased opportunity for interpersonal racism, structural racism, less community and social support, etc. I did find some suggestions that support the notion that there's this pathway, this stress pathway, that may be connecting structural racism to increased risk of stillbirth for Black moms in neighborhoods of privilege. Just suggestions that could be investigated in further study. For example, I found suggestive data that there may be a higher stillbirth risk for older Black women. As well as a risk that persists after adjusting for the level of prenatal care, suggesting that prenatal care is not the decision maker, that there may be something else going on. And then finally, this complicated table here just shows the stillbirth rates for Black moms at the top and white moms at the bottom. divided by the sex of the baby. And I just found it very intriguing that for Black moms, male babies residing in neighborhoods of disadvantage have a stillbirth rate of 12.9 per thousand, whereas male babies of Black moms residing in neighborhoods of privilege have a much higher stillbirth rate, 16.9 per thousand total births. And I call that out because there is some suggestion that the sex difference for stillbirth risk is associated with maternal stress. So my study did not investigate the stress pathway, but there's some suggestive data there. So my study had a few strengths. I looked at an area that's woefully under-researched, and I want to call out the fact that while New York City stillbirths comprise 4% of the nation's stillbirth, they comprise 15% of the nation's Black stillbirths. So this also sort of justifies the focus on New York City. I had a large study sample. I looked at 4 measures of structural racism that cover several large categories of structural racism. I used race-specific analyses. So I looked separately at Black moms and white moms so as not to have the larger stillbirth numbers from white babies overwhelm any Black-specific outcomes. I carried out lots and lots and lots of sensitivity analyses. So I poked and prodded at the analysis every way that I could think. And the results were very, very rigorous or very robust to the results that I presented to you guys. And I think another strength of this study is that it really is a bit provocative in that it raises questions about these measures of structural racism. How well do they capture structural racism at different levels of measurement? So I think it's, I'm in no way a scholar in this area, in no way. But it's quite interesting that my results kind of were very counter to the results of many other studies. And yeah, there were limitations to my study for sure. I had no data on individual stress, so no data on perceived stress of individual moms. And so I don't know, whether stress is one of the pathways that may connect structural racism to Black stillbirth rates. I also was not able to account for sibling clustering. So over a 10-year period, you would assume that there would be, a lot of moms having multiple births added to this data set. And so those babies would be more similar to each other than babies from different families. And in the normal course of things, you would want to account for that similarity, and I could not do that. So that would have the effect of strengthening any results that I find, such as that 54% increased risk of stillbirth for Black moms. If I had been able to account for that sibling clustering, I would expect the effect to be less strong. And then also there's a possibility that some of the factors that I adjusted for may be what's known as mediators, meaning they might be on the pathway between structural racism and stillbirth. For example, the proportion of folks living under the poverty line may, possibly should not have adjusted for that. However, I did do a sensitivity analysis that took that out of the model, and I still found similar results. So that's a really quick overview. I just wanted to say a thank you very much, especially to all the families whose data is represented here, and the babies who were stillborn over those 10 years in New York City, and to my colleagues. And I'm happy to answer any questions. I hope that that wasn't too technical. Yeah, so anyway.
Thank you very much, Zan. I'm seeing lots of exploding claps coming everywhere, so I think well appreciated by everybody. Very clear and overview. Great. And thank you for your willingness to take some questions now as well. So does anyone have any questions or comments for Zan? It's always silent. So while you're getting together your comments, so do feel free to either type in the chat any questions or comments, or do raise your hand as well. Mamadou.
Good morning, good afternoon, bonjour tout le monde. Et my question is about the result of stillbirth in the black group. If I understand, uh, the the five quintile,
Yes.
uh, as a high percentage of stillbirth than uh, the than four, three, two, and one. I want how do you explain this situation? It is
Yeah.
it is very it is not really normal of me because uh, in the document the one, two, three, and four as the highest stillbirth than the five. I don't
Yeah.
know if you understand my question.
Yeah, I mean that was my question. When I first did the analysis, I did it over and it was the opposite to what I expected. Um, but I have learned a lot since then. It was the opposite to what I expected, partly because of the literature that I had read, and I had a friend. I redid the analysis a billion times. I had a friend recode everything, thousands of lines of code for me. I checked everything. Um, but I'm very, very confident in the in the results. And the way I explain it is what I attempted to share in my consideration of the possible pathways. I think that we had this assumption that a neighborhood of privilege with high incomes is going to have, a really fancy hospital, which it probably does, with all the ultrasound machines and the wonderful doctors and all that stuff. And we assume that that will translate into better outcomes. Now, sometimes it doesn't because that will attract people who have higher risk who come and deliver but overarchingly, we expect that to mean a higher quality of care. And we also expect that people who live in those neighborhoods are just better off in every regard. And to me, as a person living in the United States, I think that shows, you know, a lack of understanding as I'm trying to educate myself of of the different components of well-being in a neighborhood of privilege. And um, that's the nature of structural racism, is that it's very insidious, and I explain this, or I think a possible explanation is indeed that there may be higher stress on Black individuals living in neighborhoods of privilege through multiple pathways. And as well as potentially increased provider bias in those facilities if Black moms are delivering there, which I wasn't able to assess. I don't know where they delivered. So, yeah. But I also think that this really pushes at how structural racism is measured, because I didn't see any stuff on this in the structural racism literature, and I think there should be. So anyway.
Thank you very much, Zan. I'll hand over to you, Teresa, now for her question.
Thank you. Zan, Excellent, excellent, excellent work. And I'm so glad I got to be a part of listening today. One of my questions is, and I know this isn't what you focused on, but it seems like what's really missing, and I would like your thoughts on this in the literature, is, and we have a lot of anecdotal information around this. We've had articles, we've had all kinds of things out in the news around the Black community versus the white, and how the women themselves have identified a problem, either antenatal or interpartum, yet they're not heard.
Yeah.
And then there's the problem. Or they're sent home and then they come back with a stillbirth. So did you find much in the research that you did around that, a little deeper dive into that piece?
So the only thing I was able to do to get at that, Teresa, thank you for that question, is that I did do some subsequent adjustment for the pretty poor quality data on prenatal care, maternal medical conditions, and insurance status. And that would essentially, by adjusting for those factors, I would essentially kind of take them out of the equation and see whether I still get the same results. And I did get the same results. They were slightly weaker, but similar. And so what that suggests to me is that the pathway that I was kind of exposing is not related. It may be more related to a stress pathway and maybe less related to the quality of care. However, that would 100% need to be looked at by, other studies. Yeah. So I hope that answers that question. And I also saw, but I'm happy to address that further. I just saw there's a question in the chat from Denise. Did I separate Black Americans from Hispanics because of previous studies? I actually, yes, I mean, I had to make a choice about my main analysis about what populations to look at. So for the main analysis, it's commonly done. I wanted to be as comparable as possible to the rest of the literature out there, as that would help me to get an idea of whether I was coming up with something that's reasonable or not. And typically, non-Hispanic Black and non-Hispanic white populations have been looked at in pregnancy outcomes. However, I did do several sensitivity analyses where I looked at Black and Hispanic and white and Hispanic. And then I also used several other definitions of both race groups. And again, I found very, very similar results. Yeah.
Excellent. Very interesting. And thank you for sharing the link to your paper in the chat as well, so anyone that wants to read further on Zan's work. So do we have any more comments or questions from anybody? Please do raise your hand or type in the chat.
Yeah.
Yes,
Can I have,
Adolph. Yes.
yeah,
Please go ahead.
Thank you very much. Thank you, Zan, for good presentation. And it's really the research which has a lot of information. And my question, maybe I'm not sure that was looked on based on the funding of the Black versus white stillbirth rate, which was higher to Black women. I was wondering, maybe not sure if that was looked on, or if it can be another way of looking on the case. I understand that was like the file, but is it possible to know how many antenatal care visits were done to each of the cases? Or maybe also to know if it's possible to know the gestational age of the stillbirth when to occur to those Black women, because either it can be seen the reduced antenatal care or the number of antenatal care visits or during labor to look on that disparities of the rates which has been higher to black versus white.
Yeah,
Yes.
yeah, I did look at both of those. For antenatal care, as I said, the quality of the data on the number of prenatal care visits is not great. And as I recall, there's a fair amount of missingness in for stillbirths, especially in that number. However, as I say, I did adjust in a subsequent sensitivity analysis. I did adjust for that.
Ah,
And Mamadou, can you mute
monthly.
yourself? And I didn't see any huge difference in my results, suggesting that the issue is not related, is less likely to be related to at least frequency of visits. For gestational age, I also did an analysis where I took a look the different gestational ages and found that it looks like the pattern of risk that I described to you guys is much stronger in the preterm births than it is in the term births, which is really interesting to me. Is that suggestive also of a stress pathway? I'm not sure. Is preterm birth more susceptible to stress to the effect of maternal stress than term birth? I think there is some literature on that. Yeah, but I did not adjust for either of those in the main model because they may also be mediators, meaning they may kind of diffuse the effect that I'm looking to study. And I see Sarah's saying, are there any differences in the health-seeking behavior of Black women as compared to white women in advantaged areas? I mean, it very well could be. If Black women are perceiving and or hearing about or perceiving increased instances of provider bias or not being heard in privileged areas, then for sure, I would think that that would have an effect on health-seeking behavior. I didn't have access to any of that data though. Yeah. Yeah.
Yeah, so Teresa's saying there's studies on stress and preterm birth. Yeah, great. Yeah, so I think Christy's asking the question that I was going to ask as well, actually. So maybe go
Oh
ahead,
yeah.
Zan. So yeah, what next?
Oh gosh, there's so much, but I think the three things that I would want to do are number one, I had been going to the New York State Department of Health was going to support me to share the draft findings with groups of women in the city and hear from them what their ideas were about how to explain the findings. Unfortunately, this happened right at COVID, and so all of that was not possible. But I would really like to bring these findings back to community groups in New York City to hear from them what they think some of the explanations would be. I also dearly would love to look at the results for other racial ethnic disparities, which are woefully under-examined. But particularly, I really would like to examine the possibility for a stress pathway and whether these results support the concept of weathering, which is that for Black women, the age as a risk factor is much stronger than for white women due to the cumulative effect over a lifetime of exposure to stress, particularly related to exposure to racism. I would really, really like to look at this data set from that perspective. And so that would mean disaggregating by age and also somehow getting perceived stress data to look at that as a pathway. So that would be really, really, I would really like to do that. I also think that there's for scholars of structural racism, I would love to hear their thoughts on what I found and how to accommodate these results within the ways that structural racism is measured. Yeah, qualitative research, absolutely. I mean, I think that should start with the communities where the data comes from, and I think that would be just so that would be the place to start.
Thanks very much, Zan. So, I think it's really, oh, actually, Del, you go next.
Hi, thank you so much for sharing this wonderful research, and it's really helpful for all of us. And as I am living in Pakistan, I am totally agree with your research because the multiple challenges faced by the marginalized communities, it becomes the highest risk of stillbirth. Pakistan is also on the at the high rate of stillbirth, and approximately 30.6 to 43 per thousand stillbirths totally count, and 200,000 stillbirths annually count in Pakistan. It's the estimated rate of stillbirth in Pakistan. And the cause of the lack of facilities, the lack of education. So that's why I am experiencing this in our country. So I am agree with your research. Thank you.
Thank you. Thank you so much.
Thank you very much, Del, for that. So I think, we're coming towards the end now. If you do have any last questions, please do raise your hands now or type in the chat for those. But Zan, I just wanted to ask you now that it's you've shown quite clearly just the importance of considering structural racism in stillbirth. And I'm just wondering, what as the stillbirth community can we do to address structural racism? How can we work with others, and what should we be doing in light of your findings?
I mean, that's a great question. And I think, there's so much that we need to be doing. I think that, going back to the communities from which this data came, to hear from them, their observations are, whether this is surprising or completely expected, and how that might be explained, would help to get at some of the ways that we could grapple with this issue. I really do think that part of the persistent, or maybe most of the persistence in the terrible disparities, is obviously rooted in, our historical legacy of racism across, centuries. So, that's a political and cultural shift that, you know, look at the state of the nation right now. It feels pretty pretty depressing. But I also think that a lot of these data are not well known. And I think that there's pretty low hanging fruit to at least make sure that at least the stillbirth community across America, and in maybe other countries where this might be relevant, knows the basics about, what is our stillbirth rate? What are the racial disparities? How long have they lasted? What is some of the basic what are some of the basic findings about how we might explain this, and what the potential role of structural racism might be? Um, um, it was very interesting to me that data point I shared at the one of the last slides, where New York City has 5% of the nation's stillbirths, but 15% of the nation's Black stillbirths. It took me a long time to construct those two percentages, because that was nowhere in any publication I could find. I had to pull all the numbers and do the calculations myself. Shouldn't be the case. Like, we should have that kind of thing plastered all over, those basic data items. So I think there's a lot to be said for just starting with sharing, a kind of a like 101 on stillbirth disparities in the US.
Great, excellent. I think you're right. There's lots we can learn across all countries. In the UK, where I'm based, in the last few years, we've had all our reports disaggregated by race, so we're able to look at this a little bit more. But there's so much more to be done and unpacked. So thank you for bringing it to our highlight today. So really, the final chance for anyone to have any more comments, reflections, or questions for Zan. Zan, is there anything else you'd like to say in the closing?
Oh gosh. No, other than to say that I expect that things will get a lot worse. We have a data lag of maybe 3 years in the United States at our national level, and because of the devastation that is being wrought, nationally, we're going to see increased numbers of stillbirths and increased racial disparities. On top of our historical legacy. So we have to have a, we need to expect that and maybe have a game plan. So yeah.
No, well, thank you very, very much. As a sort of cautionally less upbeat end to the seminar, but I think it's probably quite realistic as well. So thank you very much, Zan, for sharing your research and your work. Thank you for those that have come and listened and asked questions. If you do have any more questions, do reach out to Zan or anyone at ISA. We're really happy to take this dialogue forward, and we hope to see more people thinking about this in our work as we go forward. So thank you very much, everybody.